Thank you very, very much, Dr. Verma, for your kind invitation. I'm very, very happy to be with you and to come from Jerusalem, where I'm living now, and to present something on my 40-year journey on the topic of idiopathic ventricular fibrillation. So, as I told you, I'm presently in Jerusalem, living for the, and because in Jerusalem, there was a big, big, very important king of United Monarchy of Israel and Judah. His name was King David. And King David lived here in Jerusalem about 3,000 years ago. And he composed psalms. And I would like to read with you the famous Psalm 121 in the context of the territory we are all facing with the coronavirus. So I'm usually reading it in Hebrew every day. I will hope not to make big mistake reading it in English for you. I lift up my eyes to the mountains. Where does my help come from? My help comes from the Lord, the maker of heaven and earth. He will not let your foot slip. He who watches over you will not slumber. Indeed, he who watches over Israel will neither slumber nor sleep. The Lord watches over you. The Lord is your shade at your right hand. The sun will not harm you by day, nor the moon by night. The Lord will keep you from all harm. He will watch over your life. The Lord will watch over your coming and going, both now and forevermore. This was King David. Now, I'm talking about the survey, what happened with IVF. First of all, I make maybe a personal survey and to tell the people who doesn't know that, but I'm born in Tunisia, which is a marvelous country, and I was obliged to leave it in 57, to come to Paris with my family, to take my cardiology, all my academic training was in Paris, and I've had fantastic chance, privilege to meet two people with Professor Gilbert Motet, who was my mentor, who is one of the father of long QT syndrome, and will give me the love of cardiac electrophysiology and also the love of quinidine. And also Professor Philippe Comel was a very good friend, and all was in these years what we discovered was new in cardiac electrophysiology. So I moved to Israel in 78. I started to direct the EP lab there until I retired a few years ago, and I've been starting working with Dr. David Laurier, who is the director of EP lab in Hadassah University Hospital from now last 2 years. I'm very happy. It's a fantastic department, and this is my personal story. Now, let us come back. One day, about 6 months after I moved in Israel, it was this afternoon, I was called to see a patient for admitting for acute MI. So I went, I saw a patient, was in the emergency room, and I saved the floor. The nurse, okay, can admit him. But when I came back to go back to the CCU, I saw a tracing, an ECG tracing on the floor. I took it, I looked to him, and I said, oh, I've never seen that. What kind of VPC you have here with a very short carpal interval? No ischemia, nothing. The KG is normal, the QT is fantastic. But what is this short? I've never seen that. I've seen that when not in normal heart, but in patient who in a very few seconds, will have a ventricular fibrillation and will have acute ischemia or acute MI. So to whom belong this CKG? So the nurse told me, don't care, Dr. Belhassen. This is a patient who the neurologist have seen him, and he sent it home now to perform an EEG ambulatory. Okay, I said, okay, no problem. Where is the patient? This guy, I saw a patient, a 28-year-old man with his wife. He told me about 3 episodes of syncopes during the last months associated with short-lasting convulsions. This was witnessed by his spouse. Now, the convulsion and the syncope were very short-lasting and with very fast return to consciousness. The patient had no family history of sudden cardiac death. He was a heavy smoker and bronchial asthma. So I called back the nurse in the CCU. I told her we not received, admit the patient, the 70-year patient with acute MI. We are receiving in the department this 28-year-old man. A few hours later, I was called emergency because this nice guy was doing repeated ventricular fibrillation. Now, as you can see here, you have trigeminy with a very short carpal interval here of a VPC. Here you have non-sustained VT, and this guy developed more than 10 episodes of ventricular fibrillation, which were always preceded by this kind of non-sustained VT, like polymorphic VT. Most of the VF were required DC cardioversion, of course, but 2 of them in panel D and panel E were self-terminating about 15 seconds. You see here reorganization of the ventricular activity that most probably explain why the patient didn't die outside the hospital, had only syncopal episode. Now, the patient's status when he was not in fibrillation, he has no CHF, normal cardiac examination, normal echocardiogram. We did emergency coronary angiogram, and we see he had normal coronary arteries, but hypokinesia of the left ventricular apex. I think retrospectively that this was due to the multiple shocks he had. Now, the arrhythmia control was difficult, and this occurred after 48 hours following a cocktail therapy associating many medications, amiodarone IV, procainamide. What I think helped a lot in this patient was when we paced the right ventricle at fast rate. And after 2 days, he didn't have any arrhythmic event when he was paced during amiodarone therapy. Doc, what we did is the following. We continue amiodarone peros daily, 1,200, and I did an AP study. After 10 days of this therapy, I was unable to induce any arrhythmia, but don't forget that we, at this time in 70 now, we only have stimulation, which of including only 2 extra stimuli. The patient was discharged on 600 milligrams per day. 1 month later, he came back in my office to tell me that he had a recurrent syncope identical to the ones before and the time of first hospitalization. Oh, what happened here? I took him to a repeat EP study on April 1st, and quite easily, we're using double extra stimulation with a short coupling interval, 200 and 160 milligram, I induced sustained polymorphic VT, ventricular fibrillation, which required DC shock. Now, have a problem. What to do now? The patient has syncope. We are in 79, no defibrillator, nothing. I remember my previous mentor, my previous boss, Professor Motet, loves a lot quinidine. I say, why not using additioning quinidine to amiodarone. Oh, all the doctor in the department saying it's impossible, quinidine, long QT, amiodarone. I say, okay, but we can start, we can see. Okay, I, of course, succeeded in convincing the doctors. We started quinidine bisulfate. I gave a dose of 1,500 milligram. I achieved a blood serum level of 2 milligram per liter. I repeat the study on combination amiodarone and quinidine, and I was unable, despite multiple repetition of double extra stimulation at the shortest coupling interval, which result in ventricular capture, to induce more than this 3 non-sustained VT beats for the first time. So I discharged the patient on amiodarone. The treatment was perfectly tolerated clinically, only mild QT prolongation, liver and thyroid function were perfect, and what's important is that the patient remained asymptomatic during 23 years. I published it for the first time in PACE in 81 something for Dr. Verma. He told me something about 1981. I will not tell you what he said to me. So first publication, and because I tried to see what happened with quinidine in other patients, during a 7-year period, I observed 5 patients. These 5 patients with apparently idiopathic ventricular fibrillation. I did an EP study. I was able to induce sustained polymorphic VT-VF. I gave quinidine in 4 patients, and disopyramide in 1 patient. In all 5 patients, impossible to reinduce ventricular fibrillation. The patients were placed on chronic antiarrhythmic therapy with this medication and felt perfectly without any recurrence of arrhythmia during a mean of 52 months. What's important is the patient age 24 and the patient age 52 were respectively a woman and a man who were found to have Brugada syndrome only later, after Pedro Brugada reported his series. So what happened with our patient? I remind you, 23 years asymptomatic. After these 23 years, he had a syncopal episode, which was 100% vasovagal. I took him to the lab because I wanted really to see, using much more aggressive protocol of stimulation, what may happen. So I repeat now the program stimulation in this patient with using 3 extra stimuli and repetition of double and triple extra stimuli, impossible to induce more than a few non-sustained VT. So I think we can understand that in this patient, quinidine is a fantastic medication for him, not only preventing spontaneous occurrence of ventricular fibrillation, but also, and more importantly, prevented the inducibility of ventricular fibrillation at programmed ventricular stimulation. Of course, I repeat, I reported him again in heart rate in 2004. What happened with him was, unfortunately, he had to undergo a right lung transplantation in 2012. This was fantastically done, almost no complication. Of course, he was treated with anti-rejection drugs, and he was fine, continuing quinidine only after I stopped amiodarone, and of course, the quinidine level were always very well monitored. Unfortunately, about 6 months ago, following hemorrhage in the opposite lung and also limited surgical lung resection, he died. But of course, his death was unrelated to any cardiac arrhythmia. Because we were obliged to stop quinidine while he was intubated and on mechanical ventilation, interestingly developed atrial fibrillation and CT brain, suggesting recent cardiac embolic stroke was found. And it's interesting that it may be that quinidine in this patient, by preventing atrial fibrillation, also most probably preventing any embolic stroke. Now, if I summarize our case, we have a 28-year-old man with storm of idiopathic ventricular fibrillation who had no arrhythmic recurrence during more than 40 years of EP-guided therapy with quinidine, without amiodarone, and don't forget, 40 years without ICD. I told the patient, I told all the doctors that if we had been the first to implant the defibrillator in this patient in 81, he would have died of complication, of infection, of all what you want. I'm sure that the fact that he didn't get ICD is the only reason of his 40 years life with quinidine. And this is the guy, Moshe, in Ichilov Hospital, where I worked until 2015. Now, is my case the first case using quinidine in patient with storm of IVF for responses? No. There is a fantastic, when I say fantastic, it's really fantastic case published in the American Heart Journal in 49. We are dealing with, from Norway, from Oslo. We are dealing with a 38-year-old man with a 6-month history of short-lasting palpitation who was hospitalized for recurrent syncope and seizures on 6 January 1944. He had a total of 10 syncopal episodes on the day of admission, something very similar to our patient. Now, the tracing is not of good quality. I agree with you, but it is a simultaneous four-lead tracing, I think, from Siemens, the Mingograph, because fantastic for simultaneous tracing. You have here the short-coupled VPC, the non-sustained polymorphic VT, and here you have a sustained polymorphic VT flutter, what you want, ventricular fibrillation lasting about 80 seconds before a patient recovers. Now, what is interesting in this patient is when you see the onset of the onset of the polymorphic VT induction, you see that this kind of tracing is now well known in the EP community as fascicular, most probably, Purkinje potential or ectopic activity arising from the right ventricle, most probably. Now, what they did with this patient in 44, they gave quinidine, which was the only medication which was given to patients with atrial fibrillation at this time, and syncopes and ventricular fibrillation were abolished using 1,000 milligram quinidine, and then only 200 milligram a day. The patient was released home on 200 3 times daily. 1 week later, all treatment was discontinued because patient request, but 3 months later, due to recurrent syncopes, quinidine at a homeotherapeutic dose was renewed, 100 milligram daily. Please compare with the dose I have been using with my patient, which was between 1,000 to 1,500. We are dealing here with a dose of 100 milligram daily. Now, what happened in the same hospital, most probably 2 doctors who know about this patient now reporting because his patient died, but he died after 40 years. He took quinidine, and most probably quinidine at very small dose. Now, they showed here tracing, which was most probably which under went the Photoshop, Photoshop, and you say that the guy we did the figure here even forgot one of the curves here, that we see very nice tracing. So they continue the medication, 100 milligram, but the patient died very, very soon after an extensive lung carcinoma was discovered in '86. And at post-mortem examination, the heart was apparently normal with proximal AD, but the doctors really thought that the diagnosis, the true diagnosis of this patient was idiopathic ventricular fibrillation. And I can tell you, I made the calculation, this guy most probably received a low dose quinidine of most probably 100 milligram daily during 42 years. Okay, this is a fantastic case. Now, Dr. Giulio Conte from Lugano in, in Switzerland asked me to collaborate to a very important multi-center long-term registry, which has been published about 6 months ago. And in this paper, which collected 245 patients from 25 European centers, I think we did a fantastic job. Giulio did a fantastic job by collecting this experience, and we defined idiopathic ventricular fibrillation, which everybody knows it is a rare condition, as a diagnosis when we exclude all the other underlying disease. When you have a normal ECG at baseline and during follow-up, when you have no organic heart disease demonstrated by 2D TTE, by coronary angiogram or CT coronary angiogram, or enough during, I would say, the last 10, 20 years, we need absolutely that the MRI will be strictly normal. Of course, we have to exclude CPVT, early repolarization syndrome, Buerda syndrome, long QT syndrome, and short QT syndrome. Of course, also any other cardiac, respiratory, metabolic, and toxicologic cause should be excluded. Now, what we see in this kind of patient is polymorphic VTVF, which occurred on a normal QT with a short coupling of the first VPCs. I think it's important when we are dealing with idiopathic ventricular fibrillation to exclude patients in whom the VF started after a bout of monomorphic VT. For example, if you have a patient with an RVOT VT, which is very fast and which degenerated into ventricular fibrillation after 1 or 2 or 3 minutes, I don't think we should classify it as idiopathic ventricular fibrillation. Now, IVF affect both genders, which is different what you see in Bugada, in which more than 90% of patients are male. The age of onset in idiopathic VF is a little bit younger than in patient Bugada. The episode of IVF frequently occur during daily activity and not during night, as usually we see in Bugada. There is no particular geographic distribution in true IVF. I'm talking about true IVF. No familial form, at my knowledge. I don't know about that. But we have about 10% of familial history of sudden cardiac death. We have a variable EP inducibility rate of sustained PVT VF, 30% in most lab in the world, and 90% in my own lab using a special protocol. I will talk about that later. And let us see median arrhythmia recurrence in about 22% during a median follow-up of 64 months. I asked yesterday Giulio to prepare the age slide in which we have the age distribution in the IVF European survey, because it was not included in the paper. And I remind you, 245 patients, 25 centers, 59% male, median age at first VF episode, 38. Only to show you that, of course, as in Bugada, the most important age are between 27 and 48, but you have about 6% of patients less than 16 years, and quite a few, really a few proportion of patients after 16. We have 6.6% between 60 and 70, and only 2.5% after age 70. So what two very important things from this survey is the fact that recurrent arrhythmic event in patients has been documented using ICD in 22% of a patient at 5 years, and in 33% at 10 years. It means that at 10 years, about 70% of patients will not have recurrent episode of IVF. This is very important. Now, another important thing here also is the age. When you are young, when you are less than 16, the recurrence of arrhythmia, which will maybe much more higher than if you are age more than 16. So the age is very critical, and this is a big, big problem when you have IVF in very young patients. Now, let me give you now my point of view on the various possibilities how to manage idiopathic ventricular fibrillation. Of course, you have the ICD therapy. All guidelines will talk about ICD therapy. I will try to show you that we also can use, and I used it, EP-guided antiarrhythmic therapy for more than 40 years. We also have a possibility of blind quinidine therapy. You have seen the report of a patient, a case report from Oslo, and I will talk about catheter ablation. Now, let us start with ICD. Of course, for any doctors today in Chicago, in the world, you will be told that ICD is considered to be the only proven effective treatment of VTT. I completely disagree with that, but these are the guidelines. I completely disagree because ICD is expected to treat ventricular fibrillation, but it doesn't prevent it. The ideal medication, the ideal treatment should be to prevent VF and not to treat it. For example, please, I don't know if you know about this report, this case report of a patient in Bugada who had arrhythmic storms, and I find that quinidine prevented the inducibility of ventricular fibrillation. So the patient received quinidine several years until one day, somebody told him, why don't you implant ICD? Okay, he told me, I want an ICD. Okay, no problem, you will get an ICD, but never stop quinidine because you had arrhythmic storms. And I'm sure that you will have again arrhythmic storms in the future. And it's a pity because quinidine prevent arrhythmic storm. He said, okay, we implant defibrillator. And of course, he stopped quinidine. And about 6 months later, he had arrhythmic storms. But what happened with that arrhythmic storm? After 1, 2, 3, 4, 5 ICD discharge, the patient still in ventricular fibrillation. And only using the 6th DC shock, the patient was saved. And believe me, that is now taking his quinidine, he renewed it, and of course, he has his ICD. I think his ICD is completely superfluous. complication of ICD, I don't have